Now we'll go to the second session. It's a three-case presentation from the Department of Medicine, Lodh Hospital. So I invite Dr. Potputhuran sir and Dr. Romeo to moderate the.
It is my pleasant duty to introduce my colleague, Dr. Romeo Rodriguez. I hand over the mic to her to take over the session.
Thank you, sir. At the outset, I would like to thank API Kochi for this great opportunity. So we'll go ahead with our case presentations. I invite Dr. Rakesh, second year DNB resident, to start with the first case.
So before starting, I would like to thank API, the organizers of API. I would like to thank the organizers of API for giving us the opportunity to present three interesting cases from our hospital. So now coming to my case, it is the silent culprit that made the mind and heart race. So I am presenting the case of a 55-year-old female from Ernakulam who is a homemaker. Before coming to the present scenario, I would like to tell a few words about the background of this patient. She went to a hospital 5 years back with complaints of fatigability and headache, and then she was detected to have diabetes mellitus and hypertension, and she took treatment for 1 month, and she claims her BP and sugar values came back to normal levels, and so she discontinued her treatment and she never followed up anywhere after that. And most importantly, she gives a history of recurrent syncopal attacks for the past 3 years, associated with profuse sweating. And about the current scenario, the patient came to the casualty on 17th of November last year with complaints of fever, myalgia and headache for 2 days. She was found to be apprehensive and was profusely sweating. She had tachycardia and her BP was 200/110 millimeters of mercury, and she had paroxysmal AF at time of receiving in the casualty, and that spontaneously reverted to normal sinus rhythm. And her ECG showed atrial flutter with varying block, and then she was admitted for evaluation. Her blood investigations revealed an elevated total count of 22,000. Her FPS was 168, potassium was on the lower side 3.2. Her CPK and CRP were elevated 654 and 144 respectively. Her creatinine was 1.5 initially, that became normal later on. Her HbA1c was 6.4 and her urine routine showed 8 to 10 WBCs. However, her blood culture, urine culture showed no growth and her echocardiography was normal. So her clinical examination and lab investigations showed signs of infection, and we assumed the foci of infection could be a urinary source, and that was managed with empirical antibiotics. Later on, her cardiac status became stable, her blood parameters normalized, and we got a normal BP recordings for 2 days prior to her discharge, and she was discharged in healthy condition without any antihypertensives, and the patient was advised to review in the OPD after 1 week. But she came to the OPD after 2 weeks, and then she was found to be apprehensive and profusely sweating. And she gives a history of nocturnal palpitations, headache, and decreased sleep. She had tachycardia, and her BP recording was 200/100 millimeters of mercury. And the bystander was constantly saying about the presence of some social and familial stresses the patient had, and he also says they noticed a fluctuation of systolic BP of between 100 and 200 while checking BP at home. So she was started on single antihypertensive, that is amlodipine 2.5 milligram once daily, and she was advised to review in the OPD after 1 week, but she did not come up for follow-up. Then she presented to the casualty on 1st of February 2023 with complaints of fever since 2 days, nausea and vomiting, chest discomfort, profuse sweating, abdominal pain since 1 day. She was found to have atrial fibrillation with fast ventricular rate, and that was pharmacologically reverted with amiodarone. And then she had hypotension, so she was admitted in the MICU and was on noradrenaline infusion for 24 hours. Her routine blood investigations revealed an elevated total count of 22,000, CRP of 98, and potassium was on the lower side 3.1. Her tropi was significantly high, that is 12,000, but her serial tropi were negative, were coming down, and FBS was 162, and her cultures, blood culture and urine culture, were showing no growth at all. However, This time we repeated an echocardiography, and we got an interesting finding that her ejection fraction, her LV function, has come down from 60% to 40% this time, that she is having mild LV dysfunction this time. And so we sought a cardiology consultation, and they gave the impression as myocarditis because of the underlying sepsis, and they planned a coronary angiogram if the patient becomes persistently symptomatic. And we noticed fluctuations of blood pressure during the later days in hospital, and later on the BP values were consistently elevated, that she required 3 oral antihypertensives for BP control. Her general physical condition improved with empirical antibiotics, antihypertensives, and other measures, and her blood parameters also improved. And before discharge, we did an echocardiography, and that showed an improvement of the LV function from 40% to 50%. So we got a feeling if we are missing something in this patient, a middle-aged woman whose bystanders constantly saying the presence of family and social stressors that have induced anxiety in this patient, but she was found to have fluctuating BP and blood sugar values in this middle-aged woman, and she had repeated episodes of panic attacks and profuse sweating with unresolving anxiety. Also, most importantly, she was having recurrent episodes of cardiac arrhythmias and myocarditis for this patient.
So at this point, I would like to get some input from the audience. So what would you have some suggestions? Like, so I've presented this case like with 2 episodes of infection, but some striking points we have put here, like a fluctuation of blood pressure. She's having palpitation, sweating, and anxiety. So for especially for our students or PG students, any differential diagnosis you can think at this point of time by the striking points. Anything else? Because fluctuation of BP is not always pheochromocytoma.
Was the patient done an ultrasound abdomen when she was admitting, because she was a new onset hypertension?
Yeah, we
right?
have done it. We'll show
Anything?
it.
Okay.
So we have considered a few differentials before we are moving it. So we'll show you the differential diagnosis here.
So these are the differential diagnoses that we put forth initially, and the first one is the most common, from the most common to the least common. The most common one is could be a labile case of labile essential hypertension, and could be thyrotoxicosis. Then a case of panic disorder. Then a case could be a case of renovascular hypertension. Another DD was some hormone secreting tumors, especially catecholamine secreting tumors, which can be from the adrenal gland or from the extra adrenal sites. That was also a DD. And another possibility we assumed could be a case of Cushing syndrome, and could be, why not, could be a case of hyperaldosteronism. And another one is post-menopausal syndrome, considering the age and the other status of the patient.
So looking at these differentials, so I would like to ask again, like what will be the investigation, like would you suggest for this patient? So we have not gone to the invasive or any imaging investigation. So like what you think on should be the next investigation for this patient? So we just went ahead with a few investigations. So we'll continue our case presentation.
So we did a USG abdomen and pelvis for this patient, and that showed a very interesting finding, that is something that is suggestive of a left adrenal adenoma. And in order to confirm that, we went ahead with a plain and contrast CT of the abdomen, and that showed a moderate enhancing lesion with central necrosis in the left adrenal gland that was suggestive of an indeterminate adrenal lesion. And this has a peculiar finding, that is central necrosis. Well, we referred to some literatures, and we found that in similar settings of some patients with the adrenal lesions having central necrosis, they were found to have leukocytosis and features of sepsis and cardiac involvement. So we were thinking that in our case, the patient might be having a urinary source as a foci of infection in the first 2 episodes. But after going through the literatures, we were thinking like, why not, it could be because of the central necrosis of this adrenal lesion that could have caused leukocytosis, sepsis, and also cardiac involvement for this patient. So now we assume it is all because of the central necrosis of this particular lesion. So we worked up for a hormone secreting tumor in this patient after a short period of time once the patient is medically stable. We waited for some time because any kind of illness, stress, or any medications that the patient is taking can interfere with the assays that we are going to do. So the patient, this is the lesion that we picked in the CT abdomen, the left adrenal lesion with central necrosis. So the patient reviewed after 1 month, and then we went ahead with the investigations like the 24-hour urine fractionated metanephrine, 24-hour urine fractionated normetanephrine, plasma renin values, then aldosterone values, then cortisol, 8 AM cortisol, and the 24-hour urine cortisol. And all the parameters were found to be within normal limits except for this 24-hour urine fractionated metanephrine and 24-hour urine fractionated normetanephrine that were significantly elevated. So we came to a conclusion that this is nothing but a case of a catecholamine secreting tumor, and that is nothing but a case of pheochromocytoma. So we sought a urology consultation, and they planned for the surgical removal of the tumor after adequate pre-op preparation that include control of BP with alpha and beta blockers. So patient was started on taprazosine 5 mg in a hiking dose 7 days prior to surgery, and metoprolol 25 mg in a hiking dose 3 days prior to surgery, and adequate BP control was attained. Then fluid repletion was done prior to surgery, and the patient underwent surgical resection of the tumor laparoscopically on 27th of April 2023, and the patient's intra and post-operative events were found to be uneventful. Now coming to the discussion part, the catecholamine secreting tumor can be from the adrenal gland or from the extra-adrenal sites like the parasympathetic ganglia or sympathetic ganglia. So that is called as the adrenal pheochromocytoma and extra-adrenal pheochromocytoma respectively. There is no such current rule of the rule of 10 right now. The current rule of 10 is that it can be 10% bilateral, 10% extra-adrenal, 10% malignant, and it can be 25 to 33% inherited. And the most common varieties are sporadic ones, and the least common are familial ones. The familial ones could be because of a part of MEN2 syndrome, von Hippel-Lindau syndrome, or NF1 neurofibromatosis 1. And most of the patients present with panic attacks as as a presenting feature. And the classical triad of pheochromocytoma, called as the episodic headache, profuse sweating, and palpitation, need not be present in all cases of pheochromocytoma. And the symptoms are paroxysmal, and this can be due to the excess of catecholamines released by the tumors. And the patient can present as episodic hypertension, sustained hypertension, or orthostatic hypotension. Almost all the patients with the pheochromocytoma might have presented with orthostatic hypotension at some point, at one point in their life. So when will you suspect a case of pheochromocytoma? Whenever the patient is presenting with hyperadrenergic spells and case of resistant young hypertension, when you have the familial syndromes, when you get an incidental adrenal mass, and when there is a strong and significant family history. And the organ most commonly affected, as in our case, is heart, and that's called pheocardiomyopathy, and that's can result in ventricular hypertrophy, myocarditis, dilated cardiomyopathy, congestive heart failure, and coronary ischemia, which is due to catecholamines-induced vasospasm and catecholamine-driven tachycardia. And myocarditis, cardiac arrhythmias like ventricular tachycardia, atrial fibrillation are life-threatening, and that require urgent medical intervention. How will we investigate? The investigation with the highest sensitivity and specificity is a 24-hour urine fractionated metanephrines. CT and MRI are having similar sensitivity, and we also do fluorodopa PET scan and MIBG scintigraphy as investigations. And since this is a vascular tumor, we never go for FNAC for such tumors. So how will you treat? As in our case, we should treat it surgically. The surgery is a treatment of choice. We have to go for a laparoscopic retroperitoneal adrenalectomy, and most important is fluid repletion before surgery. And 7 days prior to surgery, patient has to be started on an alpha blocker like phenoxybenzamine, which is irreversible one, and phentolamine or prazosin. And 3 days prior to surgery, patient has to be started on beta blockers. And make sure you should always start alpha blockers first, followed by beta blockers, not the otherwise, because it will cause unopposed alpha action. And then the patient will go for hypertensive crisis if we are starting beta blockers first, then alpha blockers. So whenever the patient is going for hypertensive crisis, the drug of choice is sodium nitroprusside. So the post-op follow-up is also important. You have to follow up the patient with urine fractionated metanephrine values. So what all messages can you take from this particular case scenario? Well, not every case of anxiety should be managed as a case of generalized anxiety disorder or as a part of psychiatric illness. It is very important for us to recognize the classical symptoms of pheochromocytoma or the atypical presentations. And this is a potentially life-threatening condition, and if it is left untreated, it can lead to serious complications and even death. So, as in our case, cardiac complications are the most common ones and is most dangerous, and this requires appropriate treatment at the earliest. So the diagnosis is very challenging because the symptoms can be episodic and the overall incidence and index of suspicion are very low, and the patients should be definitely be monitored for recurrence of tumors. That's also important. That's all it's about. Thank you so much for the patient listening.
It's not a very rare disease. In my experience, I have seen only very few cases. The first case I remember came in with a dramatic presentation. A medical student from Dr. Ramakrishnan is here. His first cousin came to CMC Vellore with complete blindness and hypertension. He had severe papilledema, and my physician at that time, Dr. Nariyalwala, diagnosed it as a pheochromocytoma. So the first question I asked this gentleman was, those days we always look at the fundus also. Every postgraduate student will carry a ophthalmoscope and look at the fundus. Subsequently, we did this test, and this patient did not have papilledema. This is one of the conditions where papilledema would occur. I would always maintain that hypertension, almost 95 to 96% is essential hypertension. Here it is intermittent hypertension, labile hypertension. Harrison very definitely says first cause is essential hypertension before it gets established. Second point that I would like to make is, today we are bypassing clinical features. Here is a diagnosis which is made purely, this is our case, purely on the basis of clinical observation. Patient was very panicky, then many women are very panicky. This patient used to have headache, giddiness, and kind of fainting sensation with severe sweating. These are some of the markers. And I would also would like to suggest that by a good history and physical examination, somebody asked a question whether ultrasound was done. Ultrasound is next to the stethoscope. It is a routine test these days. For every hypertensive, that should be done. That can be detected. If there is a palpable kidney mass, polycystic disease of the kidney can be detected. By putting your stethoscope, you can say whether the patient has renal artery stenosis. Looking at all the pulses, brachiofemoral delay, you can diagnose coarctation of the aorta. And these are some of the common causes. And once Paul Wood mentioned a statement that taking a patient, he was looking at the fundus. Suddenly he felt for the pulse to look for, patient had papilledema and looked for the pulse, and the pulse was missing. So his statement was, when you have that kind of an experience with papilledema and absent pulses, don't consider this coarctation of the aorta as the first diagnosis. It's very rare presenting with papilledema. Somebody mentioned in the differential diagnosis, Conn's disease. 7th or 8th case of Conn's disease was diagnosed by the same gentleman, this Nariyalwala, and called her name was Mrs. John, called her Con John.
Just some thought about it. One, the patient had recurrent episodes of subsymptoms. So it looks like it was autonomic, some form of autonomic neuropathy throughout. And he went on for almost a year with the symptoms. According to, he presented first around 6 months back, right?
Actually, 5 years back, she had a episode of headache and fatigability, and she presented to a hospital that time. So we assume that all the symptoms started 5 years back.
So it's been going on for 5 years. So
Maybe, sir, it's not to our hospital. This is
Okay,
only with us with only for 3-4 months. But when retrospectively we look back, the symptoms of syncope episode and all, we asked the patient whether you had these episodes prior. Then she told that she had sweating, palpitation, anxiety. But all the time, whenever she gets this, she attributes to the family stresses. So
then it's been going on for at least quite some time.
yeah, maybe almost for 5 years, because she always says that she feels very have palpitation, sweating, and giddiness, and she used to lie down. but never gone to hospital for a workup for anything. They thought it's because of multiple problems in the families happening, and she's only female in the home and attributed to that actually.
But then going so long made me thought of other things. Why wouldn't you consider autonomic neuropathy in such situations where you would think of clinical situations where you can have autonomic neuropathy like acute intermittent porphyria and things like that? And second is, what do you expect on the biopsy of this adrenal gland which you're going to send? I assume you must have sent the gland for biopsy.
Sir.
And
Yes, sir.
what do you presume? Could it be a malignancy or a non-malignancy? Having
Sir.
had the disease for almost 5 years.
This could probably be a non-malignant case because for as to be called as malignant one, the feature that should be present in a case of pheochromocytoma is invasion of the tumor. We're not looking for the histopathology. So histopathology has no significance at all in cases of pheochromocytoma to be called as malignant or not. So here invasion was totally absent for this patient, and even after surgical resection of the tumor, we could not find any invasion of the adjacent tissues. So this could purely be a case of benign pheochromocytoma, not malignant.
In malignancy, the hormone will be dopamine. Not like methanephrine or normetanephrine. It will be like dopamine.